Postpartum Depression and the Affordable Care Act, Research and Realities, submitted by Heather Popple for Nursing 5003, Health Policy and Promotion. Postpartum depression, or PPD, is a moderate to severe depression occurring after a woman has given birth. It is common to have what is called baby blues for the first 1 to 2 weeks after birth, but postpartum depression is much more severe than baby blues. It can be diagnosed up to a year after birth, and 3 months is average. There are many possible contributing factors to postpartum depression: changes in hormones and physiology due to pregnancy, sleep deprivation, changes in work and social relationships, and anxiety about assuming a maternal role all can contribute. The largest study to date has shown that as many as 22% of women experience postpartum depression within 1 year of giving birth. Of the women who have experienced postpartum depression with one pregnancy, the risk with a subsequent pregnancy is 41%. Postpartum depression is estimated to cost over $12.4 billion of healthcare dollars each year. Some of the risk factors that are for postpartum depression include being under the age of 20, a history of drug or alcohol abuse, unplanned pregnancy, a history of depression, bipolar disorder, or anxiety disorder before pregnancy, experienced a stressful life event during pregnancy, such as the death of a family member or a breakup, experienced a health problem with the pregnancy or a baby, such as a long time on bed rest or a premature birth, single or poor relationship with the father of the baby, if you have money or housing problems, and lack of social support from friends or family. Now we're going to look at the Patient Protection and Affordable Care Act. Section 2952 is Support, Education, and Research for Postpartum Depression. A summary of the policy is that it expands and intensifies research activities related to postpartum depression through the Department of Health and Human Services. The Act enables the National Institute of Mental Health to conduct a national longitudinal study of the mental health consequences of women resolving pregnancies in different ways. It also authorizes $3 million in new grants for the states to improve postpartum services to women. So what is included in these grants? Well, included is delivering or enhancing home-based and support services, case management and comprehensive treatments, inpatient care management services ensuring the well-being of the mother, family, and infant, improving support services and providing counseling, promoting earlier diagnosis and treatment, and providing information to new mothers. Now we'll look at the history and development of Section 2952, the long road to becoming law. Melanie Blocker Stokes was a successful pharmaceutical sales manager, wife, and mother from Chicago, Illinois. On February 23, 2001, she gave birth to a healthy baby girl. After the birth, Melanie developed postpartum psychosis, which is a very severe postpartum disorder, much more severe than postpartum depression. She was admitted to the hospital 3 separate times for treatment. Each stay was 7 to 10 days. And despite aggressive medical treatment and support from her husband, family, and friends, she jumped to her death from a 12-story window on June 11th of 2001. The road to becoming a law. Carol Blocker, Melanie's mother, spearheaded a movement to bring postpartum illness, depression, and psychosis to the forefront. A bill, the Melanie Blocker Stokes Mothers Act, was also authorized by U.S. Senator Robert Menendez and Representative Bobby Rush. The Mothers Act stands for Mom's Opportunity to Access Health, Education, Research, and Support for Postpartum Depression Act. How it started was Representative Bobby L. Rush introduced a bill in the House of Representatives on February 13, 2003. The bill was referred to the House Committee of Energy and Commerce and never came out of committee. At the same time, Senator Richard Durbin introduced a bill in the Senate on February 26, 2003. The bill was referred to the Senate Committee on Health, Education, Labor, and Pensions, and again, it never came out of committee. Congressman Rush and Senator Menendez worked together for years for the postpartum depression cause, and thanks to these men, the Mothers Act became Section 2952 of the Patient Protection and Affordable Care Act of 2010. Section 2952, Implications for Practice. We need to have an effective and well-studied tool to identify these women who are experiencing PPD. There are tools out that we can use right now, like the Edinburgh Postpartum Depression Scale, but we need more tools that are more specific. We need an effective and well-studied tool to identify women who are at risk for PPD and implement early intervention techniques. And this is a multidisciplinary problem. Coordination of care and cooperation between disciplines is essential for good outcomes. This means nursing, physicians, pediatricians, psychiatrists, OBGYNs, everyone needs to be involved. Policy action endeavor. Number 1 would be education. Number 2, identification. Number 3 are shame. So who's on the front lines? Pediatricians are on the front lines. Pediatricians are in a perfect position to screen for PPD because they see the mother and the child frequently. Usually at the beginning of life, they're seeing them every 1 to 2 months. Screening for PPD is actually recommended by Bright Futures and the AAP Mental Health Task Force and is a best practice in caring for infants and their families. Yet, I spoke with 2 local pediatricians and was told that screening mothers takes too much time, that it wasn't their job, that it should be done by the OB, and that they can't bill for it. Therefore, they don't want to do it. So maybe the obstetricians are better. The obstetricians don't see the mothers as much as the pediatrician after birth, but they do still see them frequently enough to do effective screening. ACOG in 2010 and reaffirmed in 2012, at this time there is insufficient evidence to support a firm recommendation for a universal antepartum or postpartum screening. There are also insufficient data to recommend how often screening should be done. So their main organization is telling them that they shouldn't have to do it. I did speak with a local OBGYN who says that she does screen for postpartum depression, but only at the first 2 postpartum visits. This is a problem because symptoms may be latent for up to a year. Then you have the patients. I spoke with a group of 5 women. All had delivered a child within the last 10 years. Of the 5, only 2 remembered being asked by a healthcare professional about postpartum depression and if they were experiencing any postpartum depression symptoms. This is our goal, a happy mother and a happy baby. But how do we get there? In summary, we need patient education and community education. We need to encourage providers to use the tools that are available, like the Edinburgh Postnatal Depression Scale. When talking with these women, we need to ask open-ended questions to encourage them to open up. Don't assume it's someone else's problem. Assume it's your problem and that you need to screen these women for postpartum depression. And stay current with the research. It is always changing, and they're finding out new things, and new tools are coming out all the time that we can use.